Hi, everyone. My name is Paul Benson. I'm a primary care doctor in Berkeley, Michigan. I am pleased to host our speaker tonight, Zill Goldstein. We're going to have a very casual conversation all about transgender issues, and I hope that you enjoy it. Zill, I had the opportunity of hearing you speak in Mexico City in July of 2019 when we had the first international conference on transgender health. And you struck me. I enjoyed your presentation so much that's why I invited you to be here today. And it's unfortunate that there was not a World AIDS Conference in 2020, live at least. There's virtual, to perhaps have seen you again. So I know you have an interesting background. I'd like to take a moment if you could just introduce yourself and then maybe talk a little bit about Calum Lord for where you work.
Sure. My name is Zill Goldstein. I'm a family nurse practitioner, which, you know, at the time I was going through school was the fastest way to get my hands on a prescription pad. And it felt really urgent to become a medical provider to provide quality care for transgender and gender diverse people. I'm currently the Associate Medical Director for TGNB Health at Calum Lord, where we serve about 4,500 transgender people who identify all across the gender spectrum. And prior to that, I started the Center for Transgender Medicine and Surgery at Mount Sinai Hospital in New York.
Wow. What do you, can you tell us a little bit about Calum Lord? Because I get the feeling that they are a very integrated organization that provides some awesome care from what I've read and people that I've talked to.
So, well, thank you.
Sure.
We have been providing care to the LGBT community, including transgender people, since the Stonewall riots in 1969. It grew out of Stonewall and has taken a lot of different shapes and forms over the years, but basically the mission is to provide high quality care to LGBT people. So because we've been doing this for, you know, just over 50 years now, we have a lot of experience working with transgender people, and I feel really honored to be a part of this organization that is so dedicated to community health.
Sure. How many providers are there at Calum Lord?
We have about 37 right now, I believe. And we just opened a new location in Brooklyn. We were based in Manhattan in the Bronx prior to that, so we're expanding right now.
Yeah, I know in Michigan, we're seeing more and more transgender individuals step up and come out, especially at a younger age. And sometimes it's very nice to see the 14 or 15-year-old actually come in with mom and dad that are supportive. Are you noticing more people coming in for your services as compared to a few years ago?
Certainly. I mean, probably we've seen a big explosion since 2014 or so. And, you know, we started, I believe it was 2016. It was before I joined Calum Lord. We started a new location in the Bronx, and 75% of our patients identify as transgender or gender non-binary. So it really, we've seen a huge uptick there. Our youth program in Manhattan is seeing many, many more gender expansive youth. And it's really wonderful to see folks coming in with their parents. You know, 10 years ago, it was unheard of to hear of a trans person with their family fully on board and supporting their transition. And now, you know, we just have so many more people who are doing this as a family. It's really beautiful.
It is. It is. I've noticed the exact same thing here, and it is beautiful, and it makes that transitioning process so much easier. And maybe we'll talk about it in a few minutes, but I mean, I think that community support and family support is probably one of the most important things, because living a lifestyle where you're a minority and not a majority, regardless of what that issue is, it's sometimes difficult to be the minority, and that support of your own community is essential. So let's start.
Well, I'm just going to interject. We have one, just to highlight the importance of family support. There's one study, I believe it was published in 2018, looking at behavioral health outcomes among transgender youth who have family support, and there was no significant difference between the transgender youth and the cisgender youth control group. So when we have family support, we just see, you know, people who are so much happier than they have been in the past.
Absolutely. Yeah, I've identified him less now, but still exists. There's a lot of loss of self-esteem when you live in hiding for so long and when you come out. And I think it takes the community and the provider and really the whole team and a village to help a person through that so they can gain that self-esteem that is just so required. It's got to be bad. And as a gay man, I remember, you know, when I was young in the teens or whatever, of hiding myself, and it had effects. It took a long time to get over all that, and I guess it's nice to see because the newer generation of transgender individuals and the LGBTQ community in general, I think, are having a lot more acceptance by the community in the world as compared to what it was the 1950s and 1960s, you know, when I came out. And I think, thank goodness, there was a lot of pioneers that paved the way for that. And it probably said, as you mentioned, starting with the Stonewall riots to, you know, to get this process going. So let's start at the beginning. There's all sorts of spectrum from just coming out and identifying yourself as being transgender to growing old with dignity and being in your 80s and 90s being transgender. How do you handle a young person, or for that matter, an older person that is just coming out with their sexual identity? Is there anything special that you or Calum Lord does?
Sure. I mean, we really want to be tailoring our treatment of every patient to who they are and what their goals are. So I can't say that there's one special thing that we do. I like to think that we offer special care for each individual who comes through. You know, we offer an informed consent model for hormone therapy, which I think is very important. So people come in and sign a consent form, and then we are able to prescribe hormones, sometimes on the first visit. And, you know, we really want to eliminate any barriers to care because we see so many benefits for transgender people accessing, you know, what we now know is life-saving medical treatment.
Without question, it certainly is life-saving, and letting people live without without all the stress and the fear and the guilt, which, as we both know, probably interferes with their general health and well-being. Does Calum Lord offer like support groups for its clients?
We've been trying to figure out how to do that post-COVID, but pre-COVID we did.
Sure.
It's just one of those things that we're all trying to adjust to a new world. We're exploring options for maybe Zoom support groups or, you know, internet chats, but, you know, we're still in the figuring out how to bring those things back online phase post-COVID. But I think,
Sure.
you know, having a place to explore and talk about your gender is really important. And for some people, that's a support group. And for some people, that's with a therapist. And for some people, that's with their friends. But just really having a space to talk about everything that's going on where you feel safe and supported is what is most important.
Yeah, I think you bring up a great point. It's not one size fits all. Not everybody needs to see a therapist. Some people probably do. And it's some people, all they need is a support group or just a friend, whether it be a cisgender friend that's understanding or a transgender friend. But I think we both would agree that it's important that you have somebody to go through this experience with. I found in my practice that a lot of transgender individuals think it's all about the hormones, and all they're really concerned themselves with is their hormone levels and not necessarily some of the emotional well-being that goes along with it. Have you noticed that as well, as that people turn more to the physical things of hormone levels and how are you feeling today type of a thing?
Well, I think it's important to pay attention to both for sure. And I bring that up with all of my patients. But you know, the funny thing about all of these old models of hormone delivery that require assessment with a therapist first is that, you know, I don't, as a medical provider, need a therapist to tell me that my patient is trans, but I need the therapist to support my patient once they start transitioning. You know, it's after we start hormones and after we begin this process, that's when we really need the support from, you know, a group or a behavioral health provider, or, you know, someone who can help adjust to all of the changes that we go through in those first months and years after transitioning.
Sure. And I found it that really when people, but just what you said, when people start hormone therapy, that's when all these changes are. And usually it's fluctuations of hormones. When somebody's hormones all of a sudden are changed, especially if they're changed rapidly, that there's that emotional not being well because of the hormones. And I equate it to a cisgender female that prior to, you know, to having menstruation, the progesterone kicks in, lowers the estrogen, and that, you know, those hormone changes can sometimes cause premenstrual tension or irritability. So, you know, I see that and I concur with you on that in total.
Yeah, well, and you know, a lot of people always are asking about what the best way to take hormones is, you know, if it's injections or pills or patches or, you know, sublingual versus swallowing pills, for example. And, you know, the thing that I really value the most is having a steady hormone level. You know, with the injections, there's these big peaks and troughs. And so over 2 weeks, someone is really on an emotional roller coaster with their hormone levels. And I see a lot of people who are really eager to start with one method, and then, you know, we end up changing because, you know, from injections to, you know, patches or pills a lot of the time, because people can't tolerate, you know, the emotional changes that they go through. And, you know, I think that's a really important consideration, and it's something that we need to talk with all of our patients about, that, you know, keeping ourselves safe on the inside is super, super important.
Yeah, no, I absolutely agree. Does yourself or Calum Lord, excuse me, of course, when I'm always getting recorded, I get the frogs in my throat. Do you have a preferred mode of starting hormone therapy, as far as, do you go to injections first, or do you use pills or transdermals, or what is there a preference, or is it not one size fits all, it's different for everybody?
Yeah, it's not one size fits all. It is really different for everybody. Our protocols really involve discussing the range of options. Of course, there's certain times that you want to use one hormone preparation over another. For example, you know, I have a patient who has an active blood clot in her leg. And that doesn't mean that I'm not going to give her hormones. It just means that we're limited to transdermal hormones, because we know that there's no increased risk for venous thromboembolism or additional blood clots or worsening of an existing clot with transdermal estrogen. So there are certainly circumstances that lead you in one direction or another. You know, I have another patient who lost her job due to COVID and doesn't have health insurance anymore, and can't afford to pay out of pocket for hormones. So she's coming into the clinic every 2 weeks for injections, because we have a mechanism to give injections to people for free when they can't afford other forms of estrogen.
Wow, that is a very, very nice service. Yeah, I had a similar patient, an elderly woman that wound up having a pulmonary embolism. And when all it said was done and came back into my office to start therapy, I was going to recommend switching to the transdermal as well. And she told me, you know what? I'm like 70 years old, and I just don't want to be on hormones anymore. She said, I don't need them. It's not what it's about. And I respected her for that opinion and said, you know what? That's fine. If you change your mind, we can always revisit that issue at a later point in time. But I guess sometimes if you have a life-threatening event, it might be enough to kind of change your thoughts a little bit. And it's not hormone replacement therapy. that determines whether or not you're transgender or not. It's really what's up here in your brain and how you feel and think, and your body phenotype as far as how you how you dress and how you act yourself when you're out in public. That's probably more important. Would you agree with that?
Yeah, exactly. And I think that there's a lot of different, I have patients who never go on hormones, who just use, whatever method. Some of them use prosthetics, some of them have injected silicone, some of them have had surgery to create the body that they want to live in, without using hormones for various reasons. And I think, the most important thing is respecting our patients' bodily autonomy, and helping them live in the body that makes it easiest for them to move through the world.
Yeah, wow, what a great point. I probably have some transgender individuals that are not on hormone therapy yet, but wanting to go on at a later point in time. And I tell them, when you're ready, that's the right time. I'm not going to push them into anything. It doesn't make you any less of a transgender individual because you're not on hormones. So thank you. I appreciate that advice.
Exactly.
Speaking of hormones, since we kind of switched the topic to it, I'm sometimes concerned with some patients that have the motto that more is better, and they like super large doses of hormones, especially estrogens, or for my trans men, testosterone. And it's something I fear to give large, massive doses, because I'm concerned about short and long-term toxicities. And being in practice for 40 years, unfortunately, I've seen toxicities that have made me very conservative in this regard. What is your approach in discussing with your patients the long and short-term toxicities?
I mean, this blends a couple different issues that we have touched on. One of them is that there's this question that comes up about menopause. Should transgender women induce menopause by stopping hormones? We don't have any data. Unfortunately, historically, trans people have not lived long enough to be able to study what happens in old age. And so as we live longer, I'm excited to learn more about how that works. Of course, if someone is over 47 and they're starting transition for the first time, 47 being the average age of menopause, we would certainly prescribe hormones because that person has never been exposed to estrogen before. But in other cases, when do we stop? Is there a benefit to stopping? We don't know. And the same thing goes with these higher doses. We have the analogy of cisgender women who get pregnant and have very high estrogen levels. And we know that there's an increased risk for blood clots in pregnancy. That's probably more due to the fluid overload that happens than the estrogen levels, but it is something that we want to be thinking about. We don't necessarily, you only have so many estrogen or androgen receptors in your body, right? I have a colleague who introduced this metaphor to me. Think of it like a parking lot. Once there are enough cars in the parking lot, every parking spot is full. And so the extra cars just end up circling around and not doing anything in the parking lot. They can't park. It's sort of like that with estrogen and androgen receptors in the human body. Once they're all filled, there's just extra hormone floating around that may have, unintended side effects. We know that hormones affect protein CNS levels those are anticoagulant proteins in our body, and they go down when people take estrogen. So we don't know if there's a dose-dependent effect. It hasn't been studied, but we do know that that's one of the effects of estrogen. So, there's all of these things that these chemicals can do in our body that will potentially cause adverse effects. And so the Endocrine Society has recommended that we mirror cisgender hormone levels in their guidelines. So that's 100 to 200 picograms per milliliter of estradiol, or 400-ish to 1,000 ish nanograms per deciliter of testosterone, of total testosterone, depending on the assay that's used. They have different normals. And we know that, you know, cis people live to their full life expectancy with those hormone levels. So we've extrapolated that those levels are safe for trans people. You know, that's a big assumption. But we don't have the answers to a lot of the questions that are important for trans people to know. We know a little bit more about testosterone levels, right? If we give too much testosterone, there's going to be a lot of deleterious effects. One of which is that we see, you know, hemoglobin and hematocrit go up. So too many red blood cells that then clog small blood vessels and can cause early heart attacks and strokes. So we know that if we give too much testosterone, there's a pretty obvious toxicity. And that's why we monitor hemoglobin and hematocrit in routine practice when we're working with transgender people. That was a long-winded answer to what seemed like a simple question.
No, but that was great, and you know, it's interesting because I share that same philosophy with you. I mean, you bring up another point is that, you know, the knowledge base or the research for treating transgender individuals, it's at a paucity. I think maybe the United States has probably more research going on than other countries, but even with that said, it's very, very little. And many times it reminds me of the HIV world in the 1980s. We had to fly by the seat of our pants and, you know, do what we thought was a good balance to help our patients and keep them safe at the same time. And it's the same thing here. And hopefully there'll be more funding and more research, and we'll get smarter and smarter about it. And, you know, and we'll get the right formulas down and do things better. But not that we're doing them bad now, but we can always improve.
Right. Well, and it's really interesting. You know, it's cisgender people who have set the research agenda on transgender people. And so I'm really looking forward to, you know, 50 years from now, when transgender people are better represented in the higher decision-making levels of the medical industrial complex. And, you know, we won't get told that questions that are important to trans people aren't important enough to cisgender people to get funding.
Yeah, you bring up a great point. I never even thought of that before, but more input from the transgender community certainly will focus better for the issues that we need to be solving and getting better at. One of the other issues that I see in my practice, and it's a difficult one for me because I'm very anti-tobacco use for all my patients, because I realize the deleterious effects on cardiovascular and lung disease, but especially in the transgender population, for whatever reason, a lot of my transgender individuals smoke cigarettes, and I know there's a synergy between hormone replacement and the hormones and pulmonary embolisms or side effects. Do you counsel your patients on tobacco cessation, and do you have any secrets for success rate that I'm not aware of?
I mean, the best thing that any smoker can do for their health is stop smoking, hands down.
Yes.
You know, I am a former smoker myself. We see higher rates of smoking among transgender people and among LGBT people as well, and we think it has to do with minority stress. You know, there's actually some interesting mixed data, but the bigger samples that we have tend to show higher rates of smoking. So I think it's super important to quit smoking. I don't think it's a contraindication to hormone therapy, but I do think that it is very important for someone's health. And, you know, what's interesting is that as people transition more, I don't want to say that there's a hierarchy of transition. As people take more steps in transition, we see interesting things happen. You know, HIV positive transgender people are more likely to take their medicine when they're on hormones than when they're not. And all transgender people are more likely to complete preventive care screenings when they're on hormones than when they're not. And we see higher scores, you know, after hormone therapy and surgical intervention on things like depression, anxiety, and self-esteem scales after gender affirming intervention. So I think part of what you have to do is work with someone to get them to care about themselves enough to quit smoking. You know, there's a lot of transgender people with very self-destructive behaviors because we're constantly told that we're worthless, and we internalize that. And unlearning that is so hard and so complicated. But really, the key towards motivating anyone towards their health is just to help them find value in themselves.
Yeah, I could not agree with you more. And I probably relate that a little bit with HIV individuals as well. I think from all the oppressors and stigma to the LGBTQ community causes lower self-esteem, and that causes more people to smoke. And once people take action to help themselves, then the smoking seems to become less, because that's one piece of the puzzle to stay healthy. But I believe exactly what you're saying. I think the root of everything is really stigma and low self-esteem. And it's important that the medical provider or the organization work to address these emotional health issues, because it's part of a person's overall well-being. And taking care of yourself is a good way to boost your self-esteem. So I agree with you totally. You know, speaking of stigma, I don't know if you have anything to say on this or not, but I at least want to ask, and that is there any special concern or anything that you're doing at Calum Lord relating to domestic violence or violence in the community, or staying safe in the community from, you know, being a victim of violence?
I mean, this is such a hard question, but
I know it is. I do know it is.
Also goes back to stigma, you
Sure.
know, stigma and self-esteem and how much we value ourselves. And you really have to take an individualized approach. You know, all of our medical providers and behavioral health providers are trained on how to, you know, work with people who are experiencing intimate partner violence. And you know, you really have to, just like everything else, wait until the person who's affected is ready to make a change, and then support them in making that change.
Yes. I know Calum Lord is, you know, guidelines on the internet. I've looked them up many times for advice and suggestions, and I applaud you and Calum Lord for the great work that you're doing. I appreciate you coming and speaking for the Trans Michigan Health Fair. I'm out of questions. This has been awesome. Do you have any last words that you might want to say? I think we covered a lot.
Yeah, I mean, I just really want all the trans people out there to know that their lives are worth something, and that they're important, and that they're loved.
Beautiful. Thank you very much. Perhaps one time we'll have you come to Michigan when travel is unrestricted and we got happier days going on. All right, again, we've been talking to Zill Goldstein from Calum Lord. I'm Paul Benson, and we wish everybody that's listening to this and attending the Trans Michigan Health Fair that they have a very learning, great time at this fair. Zill, thank you very much. I hope to be talking again to you sometime in the future. Stay well, my friend.
Thank you. You too, Paul.
Thank you.